Good evening, all, to the 97th session of the weekly Huddle. I'm your host, Anoop Agrawal, and joining me today is my friend and co host, Praneeth Palamari. We both are cardiologists at Care Hospital, Banjara Hills. You all are quite familiar with the format of the weekly Huddle. Essentially, we take a clinical topic or a clinical case and we try to restrict our discussion around that. And while we do want to talk about guidelines and evidence-based practice, we also want to be a little bit more pragmatic, taking local factors into account and share our clinical practice pattern for a particular case or topic. Today we have selected a case which is quite routine for a cardiac practice. It is very common for a vascular practice, and it is reasonably there in general practice as well. While we often refer these cases for the vascular surgeons, I think the preliminary management is something that every general physician or a cardiologist or anybody who deals with cardiovascular disease should be quite familiar with. So I'm going to get started with the clinical case. I will put up the discussion points. As a customary to this session, I always ask my co-host Praneeth for his initial impression, and then we ask our attendees about what they would think. In the meantime, if you do have any questions or comments, you can either put it in the chat box or raise your hand and I'll give you a chance to speak. So this is a 62-year-old male. He has got a history of diabetes, hypertension. He's a reformed smoker. Now he has quit smoking for the past more than 6 years or so. That is because around 6 years back, he had a myocardial infarction, which was involving the anterior wall. He was thrombolized for that. Subsequently, he was taken for an angioplasty, and he had a stent placed in the proximal LAD. His ejection fraction, which was earlier around 35 to 40%, recovered to around 45%, and that's where he is right now. He comes in for a routine checkup. He does not have any active cardiac symptoms. He's minding his routine business without any angina or any heart failure. Recently, he has noticed pain involving calf and feet. They are bilateral, but he claims that it hurts more on the left side than on the right side. And this he has noticed for the past about 3-4 months. It has been kind of insidious, his onset, so he can't really pinpoint when exactly he started having these symptoms. But he definitely thinks that they were not present during his last follow-up that was 6 months back. He's a retired security personnel. His daily activity mostly involves morning and evening walk and running house errands, both of which he is able to do. It is only that during his morning walk, he has to frequently take pause because of his leg pain. In the clinic, when I examined his legs, it showed scant hair over both the legs. He had optimal capillary refill though, and his distal pulses were well palpable. I did order an ankle brachial index on him, which was noted to be 1.3 on the left and 1.4 on the right. He also underwent routine clinical assessment, also lab assessment pertaining to his comorbidities, which included diabetes and hypertension, and most of them otherwise were fine. So, and the medications that he's on are also quite routine. He's on aspirin, low dose, atorvastatin 20 milligrams. He takes telmisartan, metoprolol, amlodipine, spironolactone, and for diabetes, he takes dapagliflozin, metformin, and linagliptin. He was started on pre-GABA about a month or two before for this leg pain by his local physician that he's taking as well. And then he takes some other lifestyle medications like a PPI, multivitamin, and those kind of sorts. So the discussion point for this case is how to interpret ankle brachial index in this patient, and as a general, how do we interpret what is the role of ABI in our practice? What is the role of imaging in evaluating peripheral arterial disease, whether that can be the first line investigation whenever we are dealing with peripheral arterial disease? What kind of pharmacotherapy we can advise or we can prescribe to our patients who have intermittent claudication? And what would be the indication for vascular intervention, be it percutaneous or be it open bypass? So with this prologue, I will hand it over to Praneeth. Praneeth, you can give your initial impression, and then I will request my attendees to share their thoughts about this case as well. So Praneeth, you can take over.
Yeah, good evening, Anoop. So this patient who is a reformed smoker who had previous coronary artery disease and now has symptoms suggestive of leg claudication. So he kind of fits into the ASCVD spectrum. So presence of an ASCVD at one territory can by itself puts him at a risk of developing an ASCVD event in other territory as well. So CAD and peripheral artery disease. So probability of he having peripheral artery disease to begin with is very high. Now his symptoms are also suggestive of peripheral artery disease. So for me, he has a diagnosis of peripheral artery disease is made. Depending on the location of his claudication, which is particularly at calves and legs or distally around there. So I expect his level of obstruction to be around thigh level, that is at SFA level, and that is what is producing his exertional or claudication. The ankle brachial index is diagnostic of peripheral artery disease when there is ankle brachial index less than 1, something or less than 0.9. The severity of stenosis is very critical that even at resting stage, the flow is or the pressure is low, that the ankle brachial index is low, and it's a sure shot diagnosis of having peripheral artery disease, or maybe we can even say critical limb ischemia. Absence of low ankle brachial index does not rule out the peripheral artery disease. In this patient, symptoms are more relevant, and as the symptoms are there, even though ankle brachial index is normal for this patient, still the diagnosis of peripheral artery disease we should be entertained and should be investigated, be it arterial Doppler or maybe a CT peripheral angiogram to localize and diagnose the peripheral artery disease. And depending on the symptoms of this patient, plan the treatment. Now, for him, for any claudication, the most important thing will be first important thing will be to do exercise, or I would encourage him to continue to do walking as long as he is able to tolerate the claudication, or as long as his claudication distance is there, because as the exercise or the effort is put into, so is release of vasodilators, and so is development of collaterals which help in relieving the claudication. He does all those things, and if he doesn't, then probably we can give vasodilators, something like this one, nitrate releasing pentoxifillin, the Silodoc, which is commonly prescribed brand. And if he is also receiving any nitrates, probably that might help. But if he is symptomatic despite these medication, and if it is interfering with his daily life, then probably I would intervene on him, because depending again on the severity of narrowing and the location and the disease, the decision of whether it needs a percutaneous intervention versus surgery should be decided based on the anatomy. I think this is my take on this patient. I don't know whether I have missed any questions, or if there is anything, I'll answer.
So, Praneeth, at this point of time, if the patient were to come to you, would you advise him to undergo imaging?
Yes.
Okay, and what are you exactly looking at in the imaging? Like what is your target?
I will try to look at the severity of stenosis and the extent of the disease to see how much how or what would be the need for intervention if it is. If there is anything which is not very critical, which I would encourage him to encourage him to do conservative, versus if the stenosis is significant, when the probability of symptom relief is less likely, then I would equally suggest him to take a call on going for an early intervention.
Okay, the guy is not on nitrates. Is there a role for giving nitrates in peripheral arterial disease?
Less likely of getting any benefit, but I would still try.
Okay, all right. And what was the brand name of pentoxifillin, Praneeth, you said?
Silodoc.
How do you spell it?
CILODOC.
Okay. Or something of that sort. Okay.
Ah, ah.
Okay. All right, Praneeth. Thank you for your initial comments. I will continue my discussion with the rest of my colleagues. And since we have a few of my colleagues online here, anybody can just take up and share your thoughts. The floor is open. If not, then I'll start asking. Yes, Shankar sir, you want to share your thoughts about this case?
Good evening to all. This is a nice discussion today in the weekly huddle. Whenever a patient comes with a lower extremity pain, that is a claudication, otherwise known as in the Latin, it is a limping. So whenever he comes with the history of claudication, when the pain and the discomfort in the buttock, in the thigh or calf muscles, and rarely in the foot, and it is just like a cramping, aching, fatigue, weakness, or pain, and starts after some degree of exercise or walking, and quickly it will be relieved by rest, and it is reproducible. So this is known as intermittent claudication. Everybody knows about it. That is, it's a vasculogenic or a true claudication, what we say. So same type of claudication also we see in neurological disorders. So it is a neurospinal because of the disc disease or the spinal stenosis or the tumors in the spinal tract. So that is known as a neurogenic claudication. This is a spinal claudication. It is otherwise known as a pseudo claudication. It mimics the claudication, but here more than the pain, there will be the motor weakness will be more. So here, the pain comes with the erect posture. When the patient is lordotic and relieved by sitting and lying down, and especially he gets relieved by leaning forward or straightening the spine maneuvers like leaning against the wall or pushing a trolley. So with this, this neurogenic claudication will be relieved. So this neurogenic claudication or the pseudo claudication, this has to be definitely, it should be differentiated in this case because the ankle brachial index is normal, more than normal, and pulses are distal pulses are palpable. So in this case, whether we are missing any case of neurogenic claudication also we should think of. So the neurogenic claudication because of nerve root compression, because of the herniated disc, or it may be lumbar spine canal stenosis. Here in the nerve root compression, the pain radiates down the leg, normally posteriorly, and it will be sharp and lancinating pain. And most of the times it will be associated with the low backache. And similarly, the lumbar spinal canal stenosis also, the pain will be seen in the hip, thigh, buttock, and comes after walking also. And sometimes on standing also, this type of pain will be there. But this, as I told earlier, it will be relieved by rest. Also, changing the posture from lumbar flexion in the form of sitting or stooping forward. So neurogenic claudication has to be ruled out with the MRI lumbar spine so that we'll see the nerve root compression and the lumbar canal stenosis also will be detected in that MRI. And one more condition, in case of chronic venous insufficiency, what we see after iliofemoral DVT or post-thrombotic obstruction. So in post-thrombotic syndrome, we'll see this type of claudication, but this it will be worst in the thigh and groin and the tight and bursting pain, and it mostly increases after walking and subsides slowly after rest. So here we go for ultrasound scan where we'll see the superficial reflux or the deep reflux with obstruction will be seen, that will be ruled out whether we are dealing with the chronic venous insufficiency, where there is a progressive edema will be there, hyperpigmentation, eczema, and ulceration will be seen in the limb, so that we can diagnose that it may be a chronic venous insufficiency. So venous claudication, neurogenic claudication, intermittent claudication, these things should be differentiated before we embark onto the peripheral arterial disease. So here we have got an index case, the 62 years male, chronic, ex-smoker, diabetic and hypertensive, and he has got all most of the cardiovascular risk factors are there, and history of past myocardial infarction, so coronary artery disease is there. So this patient, when he comes with intermittent claudication, even in the absence of the diagnostic ABI, that is the ankle brachial index, and the palpable pulses, we have to think of peripheral arterial disease only, because most of the time the peripheral arterial disease is a systemic atherosclerotic condition, where cerebrovascular disease and the coronary artery disease may be associated with the PAD, that is a peripheral arterial disease. So why we have got, see, the first investigation we do at bedside is ankle brachial index. We apply the cuff to the arm and we inflate it, and we apply the continuous wave Doppler probe. So when the signals disappear, when the cuff is inflated, when the signals disappear, we say that it is a systolic blood pressure, and slowly we deflate it. When the signals again reappear, so that is the point where we record the systolic blood pressure. So likewise, both the arms, both the calves, both the ankles, we record. The ankle blood pressure divided by the brachial blood pressure is the ABI, that is ankle brachial index. Normally, it will be 0.9 to 1.3. When it is less than 0.9, we say that there is ischemia in the limb with the peripheral arterial disease. But why here it is 1.3 in one limb and 1.4 in another limb? Because in the 62 years old man, and is a known diabetic also, so there is a calcification of the arteries are there. When the calcified arteries are there, we get ABI, that is the ankle brachial index, will be more. Sometimes it will be normal, or it may be elevated also. And the palpable pulses can be explained with a long-standing ischemic peripheral occlusive disease, where collaterals will appear and the distal pulses may be palpable. So in that situation, how to document that the patient has got peripheral arterial disease? Then plain X-ray will reveal the calcified arteries, and especially in the diabetes and the end-stage renal disease, this arterial calcification is predominant. And in that situation, when the ABI, when we suspect the peripheral arterial disease, the ankle brachial index is normal or elevated, then we go for the exercise test, either with a treadmill or at the bedside. We can ask the patient to do heel exercises, up and down heels, that is a plantar flexion and extension. And there we will see a 20% fall in ankle brachial index. If there is a more than 20% fall in ankle brachial index, it is suggestive of peripheral arterial disease. Otherwise, we can do at the same time bedside toe brachial index. That is an ideal one when it is doubtful. So where the toe brachial index, if it is less than 0.7, it is a diagnostic of peripheral arterial disease. So having diagnosed that it's a case of peripheral arterial disease, then further investigations can be done, like a duplex ultrasound, where we'll see the absent flow in the vessels, and CT angiography or MR angiography, and conventional, even catheter-based angiography can be done to document that there is stenosis or occlusion of the peripheral arterial disease with these investigations. So coming to the management of peripheral arterial disease, as I already alluded to, that is a manifestation of systemic atherosclerosis, and usually it is associated with the coronary artery disease, cerebrovascular disease. So we are supposed to do secondary. We should supposed to go for secondary prevention regarding the cardiovascular risk factors. Like here, the patient is hypertensive. The hypertension has to be well controlled, and he is a non-diabetic. The glycemic control also to be taken care of, and already documented ASCVD as Dr. Pranith has alluded to. So here we give high dose statins to bring back the LDL cholesterol to less than 70 according to the ESC guidelines. Then though he admits that he has left smoking, but caution should be taken regarding the smoking cessation, if at all. Then therapeutic lifestyle changes, like if he's overweight, weight reduction, and especially the anti-thrombatic therapy. This is earlier we used to give DAPT, that is the dual antiplatelet therapy, aspirin and clopidogrel. But after the COMPASS trial, the aspirin 100 milligrams and the rivaroxaban, the Novak or Dovac, the new novel anticoagulants, 2.5 milligrams BID. This is an ideal combination because this has got less side effects as well as long-term benefits also there regarding both coronary artery disease, cerebrovascular disease, and the peripheral artery disease. Coming to, as Dr. Pranith has already alluded to, that supervised exercise therapy. This is quite essential in selected patients. It is quite useful also. And coming to some specific pharmacotherapy is there. That is, Celodoc is mentioned, that is a silostazole. It's not pentoxifylline. Pentoxifylline is available as a Trentol. The market is a 400 milligram capsule. So this is a silostazole. It is available in the market as Telos or Celodoc. 50 and 100 milligram tablets are available. This is a wonderful drug. In most of the cases, in 2/3 of the cases with the peripheral arterial disease, they get relieved of this claudication pain, lower extremity pain. And one more drug, this is not available in India, but it is freely available in Europe as that is a Proxylene 100 milligram capsules. That is Naftidrofuryl. This is a 5-hydroxytryptamine 2 agonist antagonist. It is a vasodilator. This has got less side effects compared to silostazole. Silostazole, as everybody knows, that is a third antiplatelet agent which we got in the armamentarium. But this is quite contraindicated in any severity of a heart failure. That we should keep in mind when we prescribe the silostazole. So the 2D echo has to be done, and we should rule out any heart failure. Here the patient has got 45% ejection fraction. He comes under HF-MREF, that is F-MRF, mid-range or mild reduced ejection fraction. So here the silostazole is contraindicated. Where if it is this Naftidrofuryl is an ideal one, but this is not available in India. But if the patient can afford, he can get it from Europe. Then other drug is pentoxifylline. It is a rheologic modifier. It increases the deformability of the red blood cells and blood viscosity, and it decreases the fibrinogen concentration and reduces the platelet adhesiveness. This is also a useful drug. When the silostazole is contraindicated in this case, we can try pentoxifylline. Other supplements are there in the market. We can give ginkgo biloba, L-arginine, L-carnitine. These can be tried in this case. Having talked about pharmacotherapy, then even then the patient is not relieved of this ischemic claudication. Then we have to document whether it is aortoiliac disease or the femoropopliteal disease or the infrapopliteal site. Then if it is a focal lesion, we can go for angioplasty or stenting. If it is a long segment, diffuse segment is there, we can go for bypass graft. That way, we can have a very good revascularization. We can get relief of this ischemic claudication and the relief of the peripheral artery disease. This is a peripheral arterial disease in a nutshell. I talked about. I will be very much enlightened regarding the interventional procedures more with the interventional cardiologists and the vascular specialists. Thank you, one and all.
Thank you, Shankar sir. That was very exhaustive and I think near complete overview of what we should know as a general about peripheral arterial disease. I do agree that there are certain conflicting things in this patient where the symptoms are suggestive of intermittent claudication, but the ABIs are above the normal range. And what you mentioned that these are most likely non-compressible arteries. And in this case, they probably are non-diagnostic. And then you did mention about the medical therapy and everything around it. I will ask my other colleagues' opinion about how they would go about this particular patient using all the information which has been shared so far. As far as the intervention part is concerned, we try to reserve our discussion outside of intervention for this huddle because the intervention part becomes very niche, and this is something which may not be of interest to general audience. But I will touch upon a little bit at the very end if we have time. So thank you, Dr. Shankar, and we will get back to you as we have more questions or comments about it. So I will ask my other attendees to share their comments. Maybe I'll ask Dr. Vijay Reddy. Vijay sir, how would you handle this particular patient from the cardiovascular standpoint? I think all the concepts have already been discussed by Dr. Shankar. So if you could tell me your practice pattern, how do you handle these cases, and tips and tricks on managing patients? Vijay sir.
Good evening to all. Basically, this is a polyvascular disease. The patient is having CAD and peripheral artery disease with post-MI with PTCS 10 to LAD with the comorbidities, requirement of smoker, hypertension, and diabetes. My points were patient is receiving guideline-directed treatment except he is receiving telmisartan. I don't recommend the telmisartan for I put him on Ramistar, this Ramipril instead of the telmisartan, and he is taking atorvastatin, the 20 milligrams. It is not sufficient. That is the cardiovascular part. Regarding to peripheral artery disease, I strongly concur with Dr. Shankar's views. The only drug that is very effective is this silostazol, not pentoxifylline, and the pentoxifylline, this trade name is Trental, and this silostazol is Celodoc or the Stilose. Number two, there are so many experimental drugs, vitamin E, beta carotene, they are all experimental. They are of futile value. The thing is, the ideal antiplatelet is not aspirin, it is the clopidogrel for peripheral artery disease. The thing is regarding ankle brachial index, lower the index, it is very significant. If it is normally, it is between 0.9 to 1.3. If it is 0.9 to 0.40, it indicates moderate disease. If it is less than 0.0, it indicates severe disease. But higher values has got no value. It indicates inelastic calcific arteries. So lower the values are indicative of disease. So, so my first investigation after diagnosing intermittent claudication, my first investigation is lower limb arterial Doppler, followed by the lower limb CT angiogram, which will indicate the site of obstruction, all those things. So this is I put silostazole for 3 months. More than that, I don't recommend. And I switch over from aspirin to clopidogrel, and I put high dose of statins, and I will, that is my strategy about this patient. Thank you.
Vijay sir, I have a few questions for you from the cardiology aspect. EF 45% stable patient for the past 5-6 years. How comfortable you are giving him silostazole? Is it contraindicated or you can try?
Contraindicated. Usually silostazole is not indicated when there is a LV dysfunction, but it is a mildly reduced ejection fraction. But still, I do advocate silostazole because it's only for 3 months.
The second question, pentoxifylline in coronary artery disease. I know there has been previous discussions on the academic forums about pentoxifylline leading to increased angina and MI episodes. You mentioned that the drug is not that effective to begin with, but do you consider pentoxifylline in patient who has CAD?
No, absolutely no. Pentoxifylline has no role.
Okay. The third and the last question to you is supervised exercise regimen is the standard therapy or gold standard therapy for intermittent claudication. How do you prescribe supervised exercise regimen to the patient other than simply saying go and walk? What is your advice to the patient?
I think intermittent compressions, that is the most ideal.
Okay. In terms of exercise or in terms of anything, are there like any programs that these patients can enroll to? Do you know of any such where they can go for, just like how we send patients for physiotherapy and whatnot? Are there programs where they can go?
Yes, they can go to the structured programs for physio.
Okay. All right. Thank you, Vijay sir, for your comments. The floor is open. If anybody has got any comments or questions, they can unmute themselves and share their thoughts. And if I don't find anybody taking up, I'll just ask opinion from the attendees. Srinivas sir, can you hear me? If you can hear me, could you please unmute yourself and share your thoughts about managing these kind of patients? Dr. Srinivas?
Yeah, thank you,
Yes,
Dr. Anoop. I think
yes, sir.
it has been extensively discussed regarding the management so far. Only thing is this patient already, it is convincing that it is a peripheral arterial disease from his symptoms, though the ankle brachial index is a little on the higher side. Now we need a definitive imaging, and as Dr. Pranita said, it looks like probably the block is in the region of the superficial femoral arteries. So we need confirmation through imaging. Definitely it is not in the inflow tract, it is in the outflow tract below the inguinal ligament. We need to see whether it is a focal disease or a diffuse disease, whether it is extensively calcified, which will further tell us whether it is going to be easy for an intervention or not. And since already this patient has significant claudication and you have said he's also lost hair on the lower limbs, that means there is a decreased perfusion and he requires an intervention if his symptoms are not responding to the medical management. So imaging based on that, we can decide based on the task classification, depending on the lesion's severity, whether it is a chronic occlusion, peripheral let-off of the vessels, the diameter of the vessels, which will further tell us whether our intervention is going to be successful or we need to plan in endovascular treatment or a surgery. Thank you.
Thank you, Srinivas sir. Shankar sir, you have anything to add?
Regarding this supervised exercise therapy, initially it should be under a physiotherapist. It comes under a rehabilitation program. But home-based that can be tried at home, that is cycling also can be tried, or ergometry, ergocycle, that also can be tried at home. That also helps graduated exercises, definitely they help in intermittent claudication.
Thank you so much, sir. For the next few minutes, I'll give my viewpoint on this topic, and in between, if you have any other thoughts, questions, or comments, you are welcome to raise your hand or unmute yourself, and I'll pause my thought process and you can continue. So, one of the fundamental ways how US training differs from Indian training that I have understood from the cardiovascular standpoint is that over there, they are quite serious about this so-called cardiovascular aspect of it, so much so that all the cardiology fellows, they are they get quite significant exposure to the vascular disease aspect of it, and that kind of makes us default vascular therapist other than being a cardiologist or so-called coronary or structural interventionist. So that does give me a little bit of better insight about how we deal with peripheral vascular disease, and it's not surprised that a certain section of US cardiologists, they end up practicing vascular medicine rather than so-called cardiology medicine. So all the questions that I have brought up and all the questions that I have asked to my attendees, I will try to give my viewpoint on this. The issues about ABI, I think that has been discussed already. When there is a non-compressible, so let me try and get a little bit more insight about this ABI concept. So if a patient has got intermittent claudication, and if the ABI is low, you have the diagnosis. Less than 0.9, that means disease is present. Less than 0.4, that means you are dealing with a very severe disease, almost reaching towards CLI. But if the ABI, if the vessels are non-compressible, where your ABI is more than 1.3, then now your ABI has got absolutely no value. You can pretty much say that that test is non-significant or doesn't exist. So a toe brachial index should be done. In this particular patient who came to me with a report that was done outside, they did not report a toe brachial index. In our hospital, every ABI, if it is 1.3 or more, toe brachial index is reported. The second thing is, if the vessels are compressible, which means if the ABI is less than 1 and you still have claudication, then doing an exercise ABI is a reasonable thing. Now, those are not done as a default. You have to ask for it. So you have to write saying that please do exercise ABI, and they'll do exercise ABI. So in this particular patient, because it was non-compressible, you can pretty much forget about ABI here on. The fact that the distal pulses are present, the fact that capillary refill is present, that kind of tells us that we are not dealing with a CLI situation. We are not dealing with a critical limb ischemia situation. We are dealing with a pure claudication. And the way I was taught was that we can think of claudication like coronary angina and chronic limb ischemia or CLI as our ischemic syndromes like your crescendo angina or your unstable angina or an MI for that matter. So and the treatment principles are in the same line, that for angina we know that a preemptive stenting or a preemptive revascularization has not shown conclusively that it improves mortality. Similarly, a preemptive angioplasty in intermittent claudication in the absence of CLI has not shown to improve outcomes. So that is why we do all this exercise therapy and we do drug therapy and everything before we embark upon an intervention, because we know that intervention do not give a very good result in the claudicant, just like in angina. The other problem with peripheral intervention is that the annual rate of ISR or instant restenosis is of the order of 30%, versus that in the coronary circulation is about 5%. So now we are talking about a failure rate of 30% at 1 year, and that should also deter us from doing intervention to begin with in this kind of patient subset. A few of my colleagues, they mentioned about imaging in this particular patient. I did not order imaging, and the reason why I did not order imaging is because I image legs only when I am planning for an intervention. If I'm not planning for an intervention and if ABI is more than 0.9, imaging does not add any value to me. In fact, I image only when either I see a clinical CLI or if the ABIs are 0.5 or less or something like that, because I do want to give them trial of this exercise therapy and medical therapy and whatnot before I embark upon intervention. And if my plan is not intervention right now, I don't image, be it ultrasound, be it CT or whatnot. I just don't do it because that information, I'm not going to do anything about it. Like in this particular patient, if it shows that SFA has got a 90% diffuse disease, I still will not intervene right now. I still will do medical management on this patient. So that is why doing an imaging right now doesn't mean anything. And if I have to intervene after 6-8 months, well, the imaging is already old. I'll have to repeat the imaging anyway. So that is why I typically don't do it. As far as medical therapy is concerned, I think Vijay Reddy sir mentioned very clearly, there is data about superiority of clopidogrel over aspirin in peripheral arterial disease. Similar data exists for coronary circulation as well, but I think for peripheral circulation, the data is a little bit more robust about superiority of clopidogrel over aspirin. Now that dictum has recently been challenged with the new COMPASS trial of low-dose aspirin with a low-dose rivaroxaban. And it does seem like that going forward, particularly in those patients who have got concomitant coronary artery disease, this might become the mainstay of treatment, where you give a low-dose aspirin and you give a 2.5 milligrams of rivaroxaban twice daily, which is what I ended up doing in this particular patient. I did not switch to clopidogrel, but I added rivaroxaban 2.5 milligrams twice daily. Of course, the atorvastatin needs to be at higher dose, so the 20 became 80. Xylostazol, I don't start in those patients who have got low EF because of the contraindication, but I do understand that in a stable patient who has got mildly reduced ejection fraction, particularly if we can observe them, then it may be a reasonable thing to start with. Pentoxifylline, I have very little experience, but in those cases where I am restricted by heart failure and I don't have a coronary artery disease, I can give pentoxifylline trial. That is also not a problem. One thing that was not touched upon in the discussion is Sglt2 inhibitors. So this patient is on dapagliflozin, and there was early on this whole data set with canagliflozin that these drugs, they actually increase the risk of leg amputation. So back in the day when people were starting Sglt2 inhibitor, mandatorily they were doing ABIs on all the patients before they were starting Sglt2 inhibitors. Now we don't do these days because that signal of canagliflozin was not reproduced by other Sglt2 inhibitor. But still that is in the back of our mind. So all the patients who have got established peripheral arterial disease, I do not give them Sglt2 inhibitors. I actually take that away, even if they have a stable coronary artery disease. I understand that the established role of Sglt2 inhibitor in diabetes, particularly heart failure, is quite good. But I become a little bit concerned whenever there is significant peripheral arterial disease, so I don't do it. Supervised exercise regimen in US, we just would write an order and there were dedicated programs where patients could enroll to. In my patients, all I tell them is that you go and you walk till you get pain. And once you get a pain, you try to walk for another 1 minute or 30 seconds or something like that. You live through the pain and walk for at least a few more seconds, because that pain becomes the trigger to get more collateral development. So that is typically what I end up telling my patients, that you simply just walk till you get a pain. Once you get a pain, try to walk for at least 30 seconds or a minute, and then you wait and you keep repeating that. You keep repeating that for about 2-3 months, and that pretty much recruits or reestablishes some of the collaterals. So I think I kind of touched upon most of the questions that, and when will I do intervention? So I do intervention when all these modalities have failed or I'm not able to give drugs. Like in this patient, I can't give xylostazol because of heart failure. I can't give pentoxifylline because of coronary artery disease. I will give him rivaroxaban. I will give him exercise. I will take Sglt2 inhibitor away. Even then, if after 2-3 months he continues to have symptoms, then I'll image his leg and then I will plan for an intervention. That is typically what I would do. And just adding a few seconds to the intervention, we try to typically just do a balloon angioplasty rather than putting a stent, unless the balloon angioplasty led to a dissection or whatnot. Understanding that the stents are at very high risk of restenosis or fracture because of the leg movement. There is a high risk of these stents fracturing. There are special kind of stents called physiological stents. The brand name is called Supera. They are slightly costly, but they are less prone to fracture, and if patients can afford, then we typically advise them to go for Supera stent, which is a little bit more flexible. It's a bare metal stent. Supera is a bare metal stent. The recent data has not been as robust as what they were early on when the stent was launched. Probably you can imagine because of industry influence and whatnot. But as a general, the stent does reasonably better as compared to the other stents. In the peripheral space, we really don't need drug-eluting stent. We can simply just put a bare metal stent, unless we are using it for below knee intervention, where you may choose a drug-eluting stent, although the data is not quite clear there as well. So that is all I'm going to talk about the intervention. Dr. Srinivas did mention about task classification. This is again something which is very simple to put it in your clinic and whatnot. And task classification kind of guides us a little bit in terms of the severity of disease, telling us whether we should go for a percutaneous intervention versus whether we should go for a open bypass intervention. So that's a very simple, handy tool that one can use whenever you have imaging in your hand. So that is all that I had. I believe that this more or less kind of completes what we have to discuss about peripheral artery disease as a general. Risk factor modification and everything that of course has been discussed so far. Any questions or comments which is there, we'll be happy to engage in discussion, and then I'll go to Dr. Somaraju for his comments. Anybody has got any questions or comments about this? Shankar sir, you have anything to add? You are unmuted.
Only two things to be noted down. If the patient has got homocysteine levels are elevated, we better treat with the B6, B12 and folic acid especially. And one more thing, in the differential diagnosis, here this is a typical case of atherosclerotic peripheral artery disease, but sometimes though it is seen more in younger people, in heavy smokers, that is the thromboangiitis obliterans. That has to be kept in mind if the patient is young enough and a heavy smoker. So here, typically the MR angiography will be typical of this TAO will be diagnosed. This I want to bring it to the notice. Homocysteine and as well as thromboangiitis obliterans. Earlier we used to see a lot of cases. Now also now and then we see this TAO, the differential diagnosis. This is the disease of exclusion.
Thank you so much for bringing that up. Thromboangiitis obliterans is something that we read in the textbook. We also see it in our clinical practice. Very difficult to treat, and commonly termed as Burgers disease. This becomes a little bit nuanced at times when we have severity. And as Shankar sir said, sometimes it presents in younger individual like 40, 45, and then it becomes very irritating. Particularly also because these are diffuse disease, so it's really, you can't put a spot stent in these kind of patients. It becomes quite difficult in that regard. Anybody else has got any other comments or questions? And if not, may I ask Somaraju sir for his opinion about today's case and discussion?
Thank you, Anoop, and thank you, everybody. And everything is well covered. I don't have too much to say on the issues that are already covered, except I'll just mention what in the last more than a decade or more, we have been suggesting that the cardiologists, cardiovascular surgeons, vascular surgeons, and interventional radiologists and physiotherapists who are required to be treating these patients. Peripheral arterial disease is not alone. It is pan-vascular disease by the time patients have peripheral vascular disease, particularly the type of patient that we mentioned. That is the reason why, if you look after these patients as a team of groups of people who work together, that will go a long way in caring for these patients. And second thing I just wanted to mention is, you, Dr. Anoop, you did mention that there is similarity between angina pectoris, chronic stable angina, and also peripheral vascular disease claudication. I don't agree that they are the same. If you have a limbic ischemia, you have time to intervene, acute limbic ischemia, but you don't have time for acute coronary syndrome, so that sometimes happen with chronic stable angina. And the clinical trials, their failure to prove that there are subsets of patients with chronic stable angina who are helped and their lives are prolonged by angioplasty and stenting. Absence of proof here should not be taken as proof of absence. We have to individualize patients with chronic stable angina. Some of them, it doesn't help prolong life, but leave symptoms, but it does help prolong life in some subsets of patients. I just wanted to point out. I also agree with Sglt2 inhibitors. They are too much is made out of them, and you should avoid them in certain situations. This is one of them. Thank you.
Thank you so much, sir. Dr. Anand, you need to, you have a question or a comment? Please unmute yourself.
Sir, thank you for covering extensively, sir. I just have one question. The patients with diabetic foot. So diabetic foot ulcers, some of them are non-healing, and they also have associated peripheral vascular disease. So what is your opinion? I mean, like, should we, I mean, like non-healing ulcers, what is the contribution of this peripheral vascular disease to this non-healing ulcer? Or should we should we just treat it conservatively, or should we wait till there is the limb is cold, or I mean, like a typical peripheral vascular disease presentation? At what point do you want to intervene in diabetic foot with vascular disease, severe vascular disease?
So, Anand, you know, the way diabetic foot differs from your traditional vascular disease is that in diabetic foot, the disease pretty much by definition extends to your small vessels and to your arterioles and whatnot. So even if you establish good circulation, the chances are that at a cellular level, the tissue may not be getting good blood. So the rules of diabetic foot as far as vascular interventions are concerned are the same, that you start with imaging, you look at where all are the critical lesions, and then you try to revascularize as much as possible. Remember, when you are dealing with a non-healing ulcer versus when you are dealing with claudication, in non-healing ulcer, you just need a vascular flow for 3 months. That's all you need. If you can establish flow for 3 months, the ulcer is most likely going to heal. After 3 months, the vessel that you intervened on, even if that vessel closes or if ISR develops or whatnot, till the time your medical therapy is working fine, the ulcer is more likely to heal and less likely to come back again. But the problem with diabetic foot is that many of the times, revascularization of the big vessels is not sufficient. So they have to do all the local therapies as well. And those local therapies involve a lot of debridement, a lot of what you call it as infection control, risk factor control, offloading the limbs, and all of those things that has to be done so that you let the ulcer heal as much as possible. A lot of these patients, they end up getting significant debridement, and the idea of debridement here is that, so the traditional way how it works is you first revascularize the big vessels. Once you revascularize, now you ask your surgeon to debride, and the surgeon debrides till the point he finds a healthy tissue with good blood flow, not just a healthy tissue, but a healthy tissue with a good blood flow, because now you know that at least till that point the small vessels are working fine and it is giving you good blood. There you expect things to heal, and that is where you do all the local therapies and whatnot. And of course, as you said, when nothing works, then you have to look at the vascular region that a particular vessel is supplying, and you may have to go for amputation in those situations. So diabetic foot definitely is more complicated disease than a typical non-healing ulcer of a peripheral arterial disease, because a typical non-healing ulcer, if you intervene and if you take care of the ulcer for 3 months, they typically heal. With diabetic foot, the success rates are lower for the reason that I mentioned. I hope I was able to kind of at least address the basic question that you asked.
Yes, sir. Yes, sir. Yes, sir. Because this is what we face more often rather than typical isolated peripheral vascular disease. That's why we have this confusion. Oftentimes, surgeons get an opinion, and we are forced to say that it may not completely recover just by improving the vasculature. And sir, oftentimes in this diabetic foot, recently I had a patient with common iliac stenosis of 80%. Common femoral multi-level vascular obstructions. And so in such a situation, what is your idea, sir? I mean, like, do you want to just improve the pressure head by improving the iliac and femoral? And this patient had a good flowing of the posterior tibial artery. I mean, like, do you believe in what is that? This angiosome kind of concept, or just opening the pressure head by improving the iliac and femoral stenosis, will it improve the healing, sir?
So whenever we are dealing with a non-healing ulcer, then the concept of angiosome is very fundamental. You have to make sure that the vessel which is supplying that area is open and it is giving good blood flow. So if you have obstruction at the inflow portion, that inflow portion needs to be opened. And even when you open the inflow portion, that particular vessel which is supplying to that angiosome, that has to open. So angiosome basically, to all the attendees, basically in the legs or in the hand or in the upper extremity, based upon what branch or what vessel is supplying, we have divided the region of the legs in various territory and call them as angiosomes. So the idea here is that if you have an ulcer on the anterior of the foot, then establishing flow to the posterior tibial is less likely to lead to healing, even if there is collateral. And the reason why is because those collaterals may not be sufficient to lead to healing. It may be sufficient to reduce or to obliterate your claudication symptoms altogether, but it may not be sufficient to lead to healing. So that is why the concept of angiosome is important. I would target all the lesions which are leading up to that angiosome. Task classification helps here, where you know that if there are more complex lesions, then maybe a bypass is a better option. But if you have simple multi-level lesions, then you can simply just go from top to bottom and do an angioplasty. You typically do, as I said, balloon angioplasty over stenting. And your target is literally just keep the vessel open for 3 months, the ulcer is going to heal.
Yes, sir.
Okay.
Thank you, sir. Thank you very much.
Any other questions about today's topic that we can address or answer or anything? If not, then I will ask Praneet to give his closing comments about today's discussion.
Yeah, no. A very common scenario. I think first important thing is highlighting the prevalence of it. We do see very commonly strokes and coronary artery disease, and peripheral artery disease is, I believe, is underdiagnosed. And unless you poke the patient about symptoms of these claudication and all, these peripheral artery disease may not be diagnosed. Having said that, after diagnosis, how do we take it forward is something which is an issue for a lot of us. And I think today we covered about how you should approach in terms of what is the symptom management, what investigation should we follow, and what treatment modalities are available. And probably once these initial evaluation is done, equally we know when to actually refer to a vascular surgeon, rather than patient just telling about claudication and then referring the patient to a vascular surgeon for evaluation management. And I think the importance of investigation in establishing a diagnosis is valid in terms of when to start. And the comment on whether to investigate at all when there is no definitive plan of management in terms of revascularization, which was highlighted by you, is equally valid. That your investigation, whatever we do, should serve a purpose. And if the diagnosis is made clinically, then probably the investigation is not worth it, versus if it is helping in aiding us decide the revascularization strategy, probably it adds value. So I think these are the comments that I could make, and these are my carry home messages from today's session.
Thank you, Praneeth. Thank you, all of you, for joining in this 97th session of our huddle. We are 100 minus 3 now. We will continue to do this till we have energy left, and we hope that we see participation from all of you going forward. As I said, most of the sessions are uploaded online. So if you have dead time in your life, you can just log on to and listen to our previous sessions as well. I thank all of you again. We'll see you next Wednesday with our 98th session. Good night and take care.